This next case is a maxillary anterior where the 4 teeth were lost 30 years ago before the patient ever really decided to have something done. The patient really couldn't stand the upper part. She's fed up with it. She said, "I don't care what, I want these 4 teeth replaced." Now, in analyzing the amount of bone that was left in this case, which I can't show you the x-rays here, but I can in the future presentations, that what we decided to do here, rather than do a block graft or some titanium particulate rebuild of the premaxilla, we decided to do a split. This slide shows the alveolar bone that's available, the thickness of it. It's pretty thin, so we decided to split it, and we started to split with a number 15 cortical, number 15 blade to make the split. Next, once you've got the original split with the blade, then we start developing the width of the split, and we're using different sized chisels to slowly but surely move this labial cortical plate out. In doing this split, you use an awful lot of finger pressure on the labial plate to control microfracturing of that plate. Also, we use a split thickness flap here because it's the only way I can get good access to it. Once the split's done, then we can go in and place our 4 implants. The 4 implants placed in here were 3.5 by 12 BioHorizon implants. The next slide shows the implants in place, what the cortical plate looks like. I took the abutments off, I placed the cover screws on, and then we did the interpositional graft, where you can see the composite graft was condensed into the intercortical spaces. Then it comes time to do a closure. The closure here, you can see we've expanded this plate so far. Getting a primary closure here is a good bit of difficulty. So what we do is do a submucosal dissection, and we bring this flat and free it up so we can accomplish at least the marginal closure in a tension-free way. Before we made the closure, we took Memlock barrier again, which was soaked in PRP this time. It was placed over the buccal cortical plate. Then we brought the flap down. Then on top of the crest of the ridge, we placed a PRGF, which is platelet-rich fibrin clot, over the exposed graft material. Then we advanced the flap, and we did primary closure with PTFE and we used 6-0 black mono to close the relief incisions. Next slide shows the provisional she wore and the post-op suture removal. On the right-hand side of this slide, you can see in this very similar case that was done the same way. This is a type 3 defect where you're going to end up with some pink porcelain quite frequently, and this shows the result of an identical case. Next, this patient comes in 6 months later. Comes time to develop the soft tissue around the future percutaneous slices. You can see where the flap is released. You can see the implant healing collar, the cover screws. The cover screws were removed, the healing collars were placed. Now, how do we develop interproximal dense connective tissue for the percutaneous sites for the future individual teeth? We did Palachi fingers, where we did slices from the palatal and moved them interproximally. And you're always going to have one shy here. So what we did is we did a split thickness pedicle flap from the interproximal distal to the cuspids, and we advanced it forward. This is what it looks like at post-op and suture removal, and also you can see it now at 2 months healing. Now we've got healed tissue here. We're ready to start our prosthetics. We also do a wax try-in, and we used regular titanium custom abutments here that have been opaqued. And we have not at this point got the final prosthesis back, but I will show that at the next setting.